All right, so the next topic we're going to venture into now is a subject of pediatrics. Now again, I want to restate for the Boards 2 students, as we are going through all these issues that we're going to go through in pediatrics, I'm going to show you how it connects back to the basics in physiology and biochemistry, or immunology for infectious disease. You will see, renal failure is renal failure, for example. Doesn't matter if it's in a child or an adult. The name of the disease that causes renal failure is different. That part is just for you to memorize. But as far as recognizing it and managing it, it's still the same physiology and therefore the same management. So before you memorize a bunch of diseases, make sure you understand basics. So pediatrics. I start out with a labor of love. This is connecting back to our OB-GYN video where we ended with the labor, the mother going into labor and giving delivery to the child. So that's where I'm going to take it from labor of self itself. You have 3 stages of labor, like we talked about at that time. Stage 1 is called the latent phase, and has 2 phases to it. Phase 1 begins with consistent uterine contractions and ends with 3 centimeters cervical dilation. Position of fetus is above the true pelvis. So we call that latent phase because he's still high up in the abdomen. If you got a prolonged latent phase, that just means that the cervix is dilating slower than usual. Normal cervix should dilate about 1 centimeter per hour for a primigravida, around 1.2 centimeters for a multigravida. So if she's dilating at a slower pace, we just say, okay, prolonged latent phase. As long as the fetus is doing okay, we do nothing. But if you got latent phase arrest, that simply means the fetus is stuck in the same position for 2 or more hours. Again, if the baby is doing fine, start oxytocin and try to push the baby down. However, if the fetus shows that he's in distress, you must do a C-section. But because the fetus is high up in the abdomen, that's why you have to do a high vertical incision in doing that type of C-section. If you remember, the muscle fibers of the uterus spin around in circles, which means if I cut top to bottom, I'm literally splitting all the fibers, which is how to remember why we do not encourage a vaginal delivery after a high vertical C-section, because you're more likely to get uterine rupture if you have a strong contraction or if mom pushes too hard. Again, if you got prolonged latent phase, then all you do is continue to watch the baby and let the baby come on down on his own. All right? Or you can start an oxytocin drip. If you got a latent phase arrest, if the baby's doing fine, again, oxytocin drip. If there's any signs of distress, immediate C-section. Now, phase 2 of the latent phase begins when the cervix is more than 3 centimeters dilated and ends at 10 centimeters full cervical dilation. That's the first stage of labor. The second stage of labor is called a very active phase. And this begins with full cervical dilation and ends with delivery of the fetus himself. Now the position of fetus is different. He is now engaged, which means he is present down inside the true pelvis. If you get prolonged active phase, again, it means the baby is taking a while to come down, but his vitals are still doing okay. If you get active phase arrest, then you have to envision that this child is stuck in the narrowest part of the canal, which is typically as he comes through the vagina, which means his shoulders could be caught. But in any case, he's being squeezed in a tight canal. That means he could suffocate. So if there's any sign of distress, you must do a C-section right away. This is when you're allowed to do a low transverse C-section incision. And in that one, 70% of the time, subsequent pregnancies can still be delivered by vaginal route. So again, remember, when the baby is high in the abdomen, if you have to do a high vertical cut, you must do C-sections for the rest of her life. But if you do a low transverse cut, 7 out of 10 times you can still do a normal vaginal delivery with no problem. So this is the second stage of labor. The active phase maneuvers, as we talked about before, the phases the child has to go through on his way out. Remember that most uteri are tilted forward, so the mom is facing to my right. The uterus will be tilted forward like that. So the baby has to descend first, flexion as he goes posteriorly, rotate internally, so internal rotation, extend his neck as he comes into the vagina, and then externally rotate. Rotate his head one more time as he comes out, so that left occiput anterior, or LOA, is the most common presentation of fetuses when they get delivered, and that happens 70% of the time. So again, descent, flexion, internal rotation since he's inside, extension as he comes into the vagina, and then external rotation as he comes out. Third stage of labor begins with delivery of fetus and ends with delivery of placenta, and as I've said before, this should occur within 30 minutes in all pregnancies. If the placenta will not easily attach, remember, we've got placenta increta, accreta, or percreta. If you remember in AIP, accreta would be first. That's when the placenta is attached a little too far deeply into the endometrium. Increta is when the placenta is attached all the way into the myometrium. And placenta percreta is when the placenta is attached all the way out to the periphery of the uterus, which means the serosa, which means it could easily attach to other structures nearby. In either case, you will notice that the placenta does not easily separate. We do not recommend pulling and pulling vigorously on the placenta because that's going to cause massive hemorrhage. Each one of these attachments, accreta, increta, and percreta, is going to lead to a lot of bleeding if you pull too hard, and therefore we're going to require hysterectomy following the delivery of the baby. So AIP, accreta, increta, and percreta. All three will require hysterectomies to follow the delivery. Now, what about signs of distress? Well, if the fetus senses any distress going on, think about normal physiology of stress perception. What is the first discharge coming out of the brain when the brain feels that you are stressed? Remember, parasympathetic first, followed by sympathetic second. That's why they call them decelerations. Remember, I mentioned these before under non-stress tests. Decelerations is really just a stress response, the parasympathetic discharge that the brain gives anytime it perceives that the baby is in trouble. So we have early decelerations. So my right hand is the uterine contraction, left hand is the heart rate. So when the deceleration lines up with uterine contraction, that is an early deceleration. This is normal uterine compression of the fetus's head. Because this is normal, we don't do anything about it because the fetus is doing just fine. All right, so again, the stress response of having your head compressed. What about late deceleration? Late deceleration, left hand, again, uterine contraction, and then the deceleration will come shortly after the uterine contraction. That's a late deceleration. That's caused by uteroplacental insufficiency. Well, that means lack of blood flow or oxygenation coming through the placenta. So what do? We initially roll mom to her left side. Why? To take any possible pressure off the inferior vena cava that might have occurred. So we have her lie on her left side. If that doesn't work, give mom some oxygen supplementation. That will usually take care of it. And if that doesn't work, you can try dilating mom's blood vessels with some IV hydralazine, see if that will improve it. And if it still does not improve, then you may have to do an emergency C-section. And then followed by variable deceleration. What happens here? In variable deceleration, you have cord compression. So now you have hypoxia causing bradycardia competing with hypovolemia causing reflex tachycardia. So now you have reflex tachycardia and reflex bradycardia caused by stress. Tachycardia from hypovolemia, decreased venous return. Bradycardia caused by hypoxia and the stress of hypoxia. And so that's why the the heart rate goes up and down, up and down. So we call that variable deceleration. But you have to perceive in your mind that you have cut off the oxygen and blood flow to the baby. And so that requires immediate C-section to bring that fetus out before any brain damage has occurred. What about if you have loss of beat-to-beat variability? If you remember in vascular phys, we said that beat-to-beat variability is the norm. Meaning that every time you stand up, your blood pressure drops by 5 to 10 millimeters mercury. And I also discussed at that time that your heart rate should go up by 5 to 10 beats, but it should not be the same number of beats each time. So if variability is the norm, between 5 and 10 beats, it then follows that if I see the same number every time, the brain is no longer monitoring the change in blood flow. And therefore, anytime you see this, you have to assume there's been asphyxiation with neurological damage. So we have the rule of 60s that govern this management. The rule of 60s involves the following. If the heart rate drops by more than 60 beats per minute at one time, that's not the brain monitoring the pulse. Or if the heart rate remains under 100 beats per minute for more than 60 seconds, it means the brain is not picking up that the heart rate is too low for so long. Or if the heart rate drops under 60 beats per minute, normal being 120 to 160, so for it to drop drastically under 60 means significant brain damage has occurred already. So loss of beat-to-beat variability is worrisome and requires emergency C-section because, again, beat-to-beat variability is the norm. Now notice again, understanding normal helps you to understand clearly what is abnormal and why we manage it the way we manage it. So now neonatology, what is that all about? Neonatology is the portion of pediatrics that occurs in the first month of life. So the first month of life, a newborn is called a neonate. So these are all the things that occur as you're coming out. So that means as a fetus coming out, I always say it's all physiology to me. So I'm going to use normal physiology to explain all the issues that we see in neonatology, or at least the most important issues. So when the fetus is coming through the birth canal, and he is being compressed by uterine contractions, that temporarily cuts off the blood supply to the fetus. That means the fetus experiences hypoxia on the way out. Well, if you have hypoxia, what hormone will respond to hypoxia? That hormone is erythropoietin. And if you have an elevation of erythropoietin, that means you're going to have increased erythropoiesis going on in the fetus as he's coming out. That means in the hours of labor, there's a lot of erythropoiesis going on. And if you remember from biochemistry, erythropoiesis in the first year of life, you have liver, spleen, flat bones, and all your long bones working. So erythropoietin is going to be the cause of polycythemia of the newborn, which is why the average baby is born with a hemoglobin of 18, 19, 20. That's a very high hematocrit. And remember, hematocrit is just hemoglobin over plasma volume. So now you got polycythemia of the newborn. You got millions of extra red blood cells that your body does not need. What are you going to do with them? That's going to cause the spleen to have to remove all these extra RBCs, and that's how you get splenomegaly. Remember, the spleen has several actions, one of which is to get rid of old red blood cells, get rid of abnormally shaped red blood cells, remove nuclear material from red blood cells, and remove encapsulated organisms. So here in polycythemia of the newborn, you've got a lot of extra red blood cells that your body doesn't need. The spleen must remove them out of circulation. This is why the spleen of a newborn is so enlarged significantly. And then as you're destroying all these red blood cells, that's going to cause a lot of bilirubin to be elevated. And that's what leads to physiologic jaundice by usually day 3 or 4 of life. So physiologic jaundice, in other words, is from increased destruction of red blood cells. 90% of it is. And 10% of it is from slow metabolism. If you remember, the liver is not completely mature till between 1 to 2 months of age. So the number one explanation for physiologic jaundice is increased destruction of red blood cells, which means you now have a lot of unconjugated bilirubin that has to be sent to the liver. Well, if you remember, unconjugated bilirubin is very fat soluble. Because it's fat soluble, that's why it can deposit underneath the skin, and this is why you get jaundice. It can deposit in the fat of the sclera, that's how you get scleral icterus. And of course, it can be deposited in the brain, causing damage specifically to the basal ganglia, which we'll call kernicterus. Now, the only time we've actually gotten kernicterus from unconjugated bilirubinemia, I think the majority of cases, almost 95% of them, have been documented in ABO incompatibility. But we figure bilirubin is bilirubin, which means any cause of hyperbilirubinemia should have the potential risk to cause kernicterus. But whenever you got damage to the basal ganglia, remember you get movement disorders. So you remember the cerebral palsy with movement abnormalities, that's called choreo atherosclerotic cerebral palsy. So kernicterus. So what do we do about it? Treatment for high bilirubin. Typically, if the bilirubin levels are above 25, then you should do an exchange transfusion. This is done with tubing with a two-way stopcock. So one tubing will suck blood away from the baby, out of the baby, and in the other direction, we will instill either normal saline or fresh blood without bilirubin in it. So that's what is meant by an exchange transfusion. And therefore, the bilirubin levels will drop immediately. So above 25, we do an exchange transfusion. But if it's above 20 for a term newborn, or above 15 for a preterm newborn, that's when we do phototherapy. Phototherapy is done with a wavelength of 270 nanometers. That wavelength is similar to the wavelength you see when there's an eclipse. And whenever there's an eclipse, remember they tell you do not look directly at it. Why? Because it can damage your retina. Well, so can this wavelength, which is why we put a mask over the baby's eyes before you turn on the lamp. Now, because it's possible that a mistake can be made and the baby's eyes could be harmed, they now have bilirubin blankets, so Billy blankets, because the surface area on the front of your torso is the same percentage as the surface area on the back of your torso, which means we can remove bilirubin at approximately the same rate, and that's what we see. But now there's no chance of the baby rolling over this early in life and looking directly at the light. And even if he was accidentally rolled over, he could not see the light. So again, when the bilirubin is above 25, you do an exchange transfusion. Above 20 for a term or above 15 for a preterm, you do phototherapy. Well, when is a bilirubin level of concern and you have to worry about it as a physician? 3 reasons for worrying about a high bilirubin level. Number 1 is when bilirubin is high on day 1 of life. There's no way that can be physiologic jaundice. Day 1, the spleen has just started breaking down bilirubin. You should not see jaundice that fast. So suspect something else. Number 2, bilirubin is mostly conjugated bilirubin. Because remember, before it gets to the liver, we call it unconjugated or indirect bilirubin. That's what we expect in normal physiologic jaundice. But if there's a problem with conjugated bilirubin, that means it's already gotten to the liver, it's been conjugated but can't get out of the system. You always think about an obstruction to the biliary tract. And then number 3, if the bilirubin rises faster than 5 milligrams per deciliter in a 24-hour period, suspect that something else is causing this elevation. Well, what should I suspect, though, when I see bilirubin that follows one of these 3 trends? Number 1 is sepsis. Why sepsis? Remember, when you have sepsis, blood pressure drops. If blood pressure drops, you now have a relative hypovolemia because blood has now flowed into areas which weren't normally open because of endotoxemia. That means less is returning to the heart. Well, anytime your body perceives hypovolemia for whatever reason, remember the 2 systems that lose their blood flow first, skin and GI tract. Well, then that means all the bilirubin being made by the breakdown of red blood cells by the spleen cannot be sent to the liver for decontamination because the GI tract, and of course the liver is part of the GI tract, the GI tract has lost its blood supply now. So sepsis is number 1, and you worry about that first. On a test question, you must pick sepsis as your number 1 concern because that's what's going to kill that child the quickest. Remember, he has no resistance at this point in time. Number 2 is hypoglycemia. Why hypoglycemia? So it can come from glycogen storage diseases. It can come from hypoglycemia due to inadequate feedings or inadequate processing, or it can cause from galactose metabolism problems. But either way, you need glucose to conjugate to bilirubin. Remember, it's called bilirubin diglucuronide, which means 2 glucose molecules are attached to bilirubin in order to get rid of it. Remember, the liver takes anything that's large and fat soluble and conjugates something that's water soluble to it. In biochemistry, we discussed the number 1 structure used to conjugate to molecules, remember, was acetyl groups. So acetylation was number 1. But in the case of bilirubin, it's glucuronidation, i.e. glucose. So hypoglycemia can lead to hyperbilirubinemia. Hypothyroidism can lead to hyperbilirubinemia. Why? because you have the permissive hormone, which is now missing. Remember, without the thyroid hormone, no organ can work properly, and that's why hypothyroidism leads to this. Remember, if mom is on an anti-thyroid drug like methimazole or propylthiouracil, then there's always a chance the fetus could suffer from the effects of that drug, specifically methimazole. Remember, PTU does not cross the placenta. So if mom is on methimazole, that crosses the placenta because it's fat soluble, and so the baby will suffer from hypothyroidism, and then you'll have a problem this early. Or if you have thyroid aplasia or agenesis, you'll have the exact same problem. And that's the most common problem we see in a newborn. And then galactosemia. And that's because galactose is the source of glucose for the newborn, and so it really works right into hypoglycemia. So these are the main things you always worry about and rule out before you worry about anything else. Then if there's mostly conjugated bilirubin, then you should think about an obstruction of the biliary tract. So we call that cholestatic jaundice. In cholestatic jaundice, then you should think about what's going on in the biliary tract. The number one cause for an obstruction of the biliary tract is called a choledochal cyst. The first thing on the list for you to think about. A choledochal cyst means a cyst in the biliary tract. Simple cyst, but however, it's causing obstruction to the biliary flow, which means you can't get rid of bilirubin that has already been conjugated. And that's why you get conjugated bilirubinemia. Second one is biliary atresia, in which the biliary tract is not even connected to the second part of duodenum. So that means biliary sludge comes out, and then it cannot enter the duodenum, so it's all going to back up. So biliary atresia, that child has to undergo surgery to reconnect the biliary tract to the second part of the duodenum. And the choledochal cyst, simple surgery to remove the cyst. And then the third one is annular pancreas. Annular pancreas, meaning around, annular. What happens is the head of the pancreas is the one causing the problem. And the head of pancreas is divided into two parts. There's a dorsal portion, that means the one that goes behind the duodenum, and there's a ventral portion, ventral meaning front. Both of them are supposed to fuse together and then go behind the duodenum. In an annular pancreas, the dorsal portion went behind the duodenum, but the ventral portion went around the front of the duodenum, so now you really have a sling around your duodenum. And that sling then causes a compression of the duodenum, including the biliary tract, and that's how you get biliary obstruction. These are much more common before you worry about the enzyme problems that they talk about in the books. In Gilbert syndrome, that can occur in anybody. This is really from the effects of hypovolemia. Remember, anytime you're hypovolemic, you lose blood supply to the skin and the GI tract first. So this can happen in any dehydrated person, whether it's a neonate or an adult, doesn't even matter. All you do is hydrate the person and the illness goes away. So these people just have mild elevation of bilirubin, but no other liver problems whatsoever. Again, hypovolemia is the cause, so fluid hydration will take care of it. Then there's Crigler-Najjar. In Crigler-Najjar, you're missing the enzyme glucuronol transferase. You're missing the enzyme glucuronol transferase. So without that enzyme, you're not able to conjugate bilirubin into bilirubin diglucuronide. But you're also not able to detoxify a lot of other things. And that's why there's a type 1 and a type 2. So type 1 is complete deficiency of the enzyme, and it's incompatible with life, so this child will not live very long. Type 2 is a partial deficiency, and so you'll see a combination of conjugated and unconjugated bilirubin in this child. So that's Crigler-Najjar. And then there's Roters and Dubin-Johnson. In Roters and Dubin-Johnson, the problem is you can conjugate bilirubin, but you're not able to transport that large molecule into the gallbladder for storage, to wait for later for CCK to contract the gallbladder and squeeze everything out. So in Roters, it's just mild the impairment in the transport of bilirubin, conjugated bilirubin into the gallbladder. Dubin-Johnson is a more severe form, and that's why in Dubin-Johnson you see the black pigment accumulating in the liver, simply because byproducts of red blood cell breakdown, bilirubin breakdown, can be black. But again, think of the top causes before you worry about rare diseases. So choledochal cyst, biliary atresia, annular pancreas are the first three things I want you to think about when you have cholestatic jaundice.